Good afternoon. My name is Dr. Rolando Barrios, and I am the Senior Medical Director of the BC Center for Excellence in HIV/AIDS. Welcome to Chapter 5 of the BC-CfE Anniversary Conversation Series. 2022 marked 30 years since the creation of the BC Center for Excellence in HIV/AIDS, and the aim of this series is to celebrate and commemorate the journey and the accomplishments of the community, advocates, researchers, and healthcare providers in that have worked to turn the tide of HIV in British Columbia. Today's session is titled Building from Treatment as Prevention, Where Does HIV Research and Care Go From Here? And we will be joined by Dr. Kate Salters. Kate Salters is a senior research scientist with the BC Center for Excellence in HIV/AIDS based at the Hope to Health complex. Her research program focuses on utilizing epidemiology and health services research methods to inform clinical care and health system planning. Dr. Salters completed her PhD in health science from Simon Fraser University in 2017, and her doctoral work focused on epidemiology of cancer among women living with HIV. Welcome. I would like to take a moment to acknowledge with gratitude that our place of work is on the traditional, ancestral, and unceded territories of the Coast Salish Nation, the lands of the Musqueam, Squamish, and Tsleil-Waututh. This acknowledgement is a reminder of the discriminatory, racist, and colonial practices that have had a lasting legacy and continue to create barriers for Indigenous people in our healthcare system. Dr. Salters have received grants and research support from the CHR, Gilead Science, Merck, and VCHRI. She has received honoraria from Gilead Sciences. The content of this presentation has been developed by Dr. Salters. Grants and funding has been paid to the institution. Where possible, both positive and negative trials will be mentioned, and generic names of medications are used in place of brand names. In this chapter, we will first review how the principle of treatment and prevention informs health research. Second, explore research as it relates to supporting people living with HIV in BC. And finally, discuss how the treatment as prevention framework can be applied to other conditions. I will now pass the microphone to Dr. Kate Salters.
Thanks, Rolando. And thanks for the invitation to present today. And I'm very happy to be Chapter 5 of this series of conversation events. I first wanted to situate our conversation here with this image, which is a graph from 1985 onwards, demonstrating the number of AIDS-defining illnesses in British Columbia. And we've divided this into the pre-triple therapy era, known as the pre-HAART era, the HAART era, which is usually defined as 1996 onwards, where we had the advent and implementation of triple therapy for HIV. And you can see the subsequent decline in AIDS-defining illnesses after that. And then in British Columbia in 2010, really marked the start of what we call the treatment as prevention, or the TASP era. And you can see over time that there's been this continuous decline in AIDS-specific illnesses in the province of BC. And on World AIDS Day in 2019, Minister of Health Adrian Dix declared the end of AIDS as an epidemic in BC with Dr. Julio Montaner, really demonstrating that the cases of AIDS-defining illnesses had fallen by 92% in the province. And I'll highlight here that while this graph ends in 2018, that's actually when the implementation of the provincial PrEP program came in. And we've seen further declines in the incidence of AIDS-defining illnesses, as well as new cases of HIV in the province. So we're really talking about this new era of supporting people living with HIV, and that's where I really want to pick up this conversation. And I think that follows some of the previous conversations in this series. And I'll share that a few years ago, this very nice paper came out from Michelle Olding and colleagues here, looking at a review of what really was specific in BC to lead to this drastic improvements in HIV outcomes. And they really categorized the three major interventions that were a part of this Stop HIV/AIDS intervention in the province as being tied to either biomedical and health services interventions, community interventions and structural interventions. And what that meant was that this was not just one event that took place, meaning that it wasn't just as simple as new modern drugs with higher tolerance and lower side effects being introduced to the market, but really it was a health system change that accompanied this advent of modern therapy. And some of the biomedical and health services changes included new drugs, but it included also enhanced monitoring and surveillance, access to harm reduction services, substance use care, point of care testing, and so on. And this was also supported by community interventions. That meant the scale up of peers and peer navigators, peer education and outreach, other public health education campaigns, and other kinds of combined or integrated care programs that supported people living with and at risk for HIV. And then also the structural components, which included enhanced guidelines for testing and treatment, and addressing some of the financial barriers and costs that were providing barriers to care, and also just access to healthcare and treatment as well. So I really like to highlight this because I think it's nice to remind ourselves that it wasn't just these modern therapies, but there was a very intentional health systems response that was coordinated, that supported these positive changes in the province. And I think this is reflected in what we've seen here. And this paper is really showing the median times from when folks are diagnosed with HIV to when they start treatment. And that's represented in the orange bar here. And then in the green, the time from starting treatment or starting antiretroviral therapy to viral suppression. And you can see here the change occurring after the implementation of the Stop HIV/AIDS program. And if we follow to the end of the study where they look in 2016, the median time from diagnosis to treatment initiation was about a month, as well as time from treatment initiation to viral suppression. And so this represents improved clinical outcomes, reduced mortality, but it also highlights that it's not just surviving with HIV, it's also promoting and supporting people living with HIV to thrive. And as such, I think this suggests that new goalposts are needed as well. And this figure, I think, well represents this integration of both monitoring and evaluation and research with our testing and our treatment prevention efforts. So really, I see this as being at the foundation. We have a very harmonized approach to HIV testing, treatment, and prevention efforts. And that includes a monitoring system in the drug treatment program, the PrEP program, and the Stop HIV/AIDS initiatives. On top of that, we have not just settled for the status quo, and there has been concerted effort to really continue to monitor and provide quality improvement interventions to address some of the pervasive gaps that continue to exist. And I'll give an example of the RETAIN initiative in a couple slides, but I really want to highlight how this really is an additional component on top of the kind of traditional testing and treatment efforts that we see in the province. And then we see this research and evaluation as being another important component that really should be embedded in order to give that feedback. And we often hear in health sciences about this gap in terms of knowledge translation and actually implementing change. And I think BC is a leader in showing that integrating health service research, monitoring, and evaluation can speed up that process. And it increases the chance that we will learn more quickly from some of the gaps or some of the areas for improvement and be able to implement those changes so that we can improve the lives of people living with HIV. And a part of that, as I've mentioned, is as part of this monitoring is what's provided in the Stop HIV/AIDS quarterly monitoring report. And this really demonstrates the strength of ongoing monitoring and evaluation to identify these gaps. For example, we see, and these are data from the Q4 2016 report from Stop HIV/AIDS, we can see here that we use the cascade of care to determine how likely people are to be retained at different parts in the continuum of care for HIV. And this ranges from being able to be linked to care, to retained in care, to starting treatment, and then being supported to be adherent and then ultimately virally suppressed. And we see in this province, and we see in many jurisdictions, that women tend to have greater attrition across the cascade of care. And so understanding how health services may need to improve to be specific to women, for example, is one part of doing this quarterly monitoring report, so that we can really look at what women-centered healthcare can look like to address some of these gaps. Additionally, when the data in the cascade of care were stratified by people who inject drugs, or PWID, we did see that people who inject drugs in the program tended to have poor outcomes in the cascade of care, likely attributed to various barriers to care that they're facing. And so noting these gaps in terms of our health service provision is really important for our ability to understand how this is reaching all populations. So I mentioned I'll highlight the Retain initiative. So the Retain initiative in the province it's called the re-engagement and engagement in treatment for ARV interrupted and naive populations. And this is really a routine system-wide intervention whereby individuals who have not picked up their medication for a period of time are reviewed in the system, and through our centralized pharmacy program in the drug treatment program here at the BC-CfE, that would trigger a series of alerts that would go out to the appropriate care provider. And that care referral program would support that individual if they need to get reconnected to care. And that usually triggers around the 4-month mark. And a few years ago, last year, an evaluation was conducted by Dr. David Moore and our colleagues here, looking at what the impact of this referral system was on actually re-engaging individuals living with HIV who have stopped taking antiretroviral therapy or who have had a treatment break. And what was, I think, really impactful from this research is that the time from interruption to reinitiation had declined because of Retain, meaning that the Retain system had effectively lowered the amount of time people remained off of treatment. So this intervention was really seen as a promising way to better support people to re-engage in HIV care. I think another point that's really important is that actually very few clients, when they were approached by healthcare professionals through the Retain system, actually declined ART. So they declined, they didn't want to recommence with treatment. And the vast majority of individuals shared that they were experiencing various socioeconomic struggles or housing struggles or other life events. So we were really grateful in 2020 to receive a grant from CIHR to evaluate this initiative. And our program called the SHARE project was meant to be a qualitative evaluation so that we could understand both the healthcare provider and the client experiences of this Retain initiative. And this was a collective effort. So I'll share that this is a research, academic and community researcher partnership. And we're very grateful for our community partners for this work. And we also conducted this research during COVID, which presented itself with a whole other set of challenges. And I'll just briefly share some of the key qualitative outcomes or qualitative themes that came out of this research. The first one was that as a system, we really need to reframe what treatment breaks are. And you'll notice that I use the term treatment breaks and not treatment interruptions, as that's the terminology that has been preferred. And a lot of the time we were hearing that clients had a lot of different factors that were leading to them stopping treatment. We also heard that individuals had a hard time re-engaging with healthcare because they didn't want to be chastised or they didn't want to be blamed for their time off of treatment. So this reframing of treatment breaks was quite profound in the qualitative work we did. Secondly, the work really assured us that comprehensive person-centered care was really the way forward to better support clients who had taken a treatment break. A lot of clients recommended or acknowledged that having healthcare that really saw them as a whole person and saw their mental health, their substance use, their other realities that were going on, aided them in getting back to their HIV care as well. And then lastly, what really came out in these interviews was supporting sustainable connection to care, that, reconnecting people to HIV care and reconnecting on HIV treatment was one piece, but actually sustaining those folks over time was really important. And so many people shared that feeling more a part of their life was a really big part of staying connected to HIV care. And that included their own personal connections in their life, but it also included these connections and continuity of care with their healthcare providers. And this really, I think this work parallels to the work we've done with the SHAPE cohort quite well. And the SHAPE cohort is a prospective cohort study that we established in 2016. And this was really designed as being the Stop HIV/AIDS program evaluation study. And so in January 2016, we launched this project, and it really was designed to examine how HIV and healthcare is experienced by people living with HIV. So in 2016, we recruited 644 people living with HIV across the province in all of the different health authorities. And we tried to represent this cohort to be reflective of the general population of people who are engaged in HIV care in the province. And I won't go through, but this gives you a little bit of a snapshot as to who is in the cohort. And I'll just note that in keeping with the growing and aging demographic of people living with HIV, that over half of our sample in SHAPE were over the age of 50 at the time of entry into the cohort. And we've shown here before, I showed in a previous slide, that in the Stop HIV/AIDS era, we have more timely initiation of antiretroviral therapy, and we have more timely viral suppression being achieved by individuals who are started on treatment. So the slides on the right here are really just demonstrating that individuals who were started on treatment prior to the Stop HIV/AIDS treatment had a longer duration to the time that they either started on treatment for a diagnosis or were virally suppressed after starting on treatment. However, I just want to draw your attention to the figure on the left, because I think this is really, the piece that speaks to the health system's response and the community response. And when we asked individuals at the time of their HIV diagnosis what services were available to you, overwhelmingly, we found that individuals who were diagnosed after the implementation of STOP, they were more likely to have regular follow-up with a medical professional, have nurse consultation, be referred to another medical professional, and also have peer support. And these are all pieces that we found in our qualitative work also to be supportive in not just engaging in care, but staying connected to care. One of the pieces that we've been looking at within the SHAPE study as well is, not just how people are doing on HIV treatment and HIV specific outcomes, but how they're doing and faring in other parts of their lives. And one key part of that is understanding what other factors are leading to the increase in mortality among people living with HIV in BC. And I'll highlight here that these data, they haven't been published yet, but they're currently under review. And we found that 71 people in the SHAPE cohort, and I'll just remind you that there's 644 people in the cohort. So that means that over 11% of people in the SHAPE cohort had passed away within 5 years of the study. And I think that really took our study team by surprise and was really a somber reminder that there's a lot of other competing realities and competing health inequities facing people living with HIV in BC. So of these 71 people that have passed away in the SHAPE cohort, a large proportion of them have passed away from overdose or from the ongoing toxic drug supply crisis. Some have passed away from non-AIDS defining illnesses. And importantly, very few people, I think 5 people, passed away from HIV-related complications. And this really highlights that we're doing a very good job at supporting people living with HIV with their HIV care, but that doesn't necessarily mean that we're addressing all of the other competing realities that people living with HIV are facing. I want to point out that the large proportion of unknown deaths here is likely attributed to, or could likely be attributed in the future, to overdoses. We know with the coroner's report, it can sometimes take time for these unknown causes of death to come out. And so the large proportion of unknown deaths lead us to believe that there's potentially some unidentified cases of overdose in this cohort. On the right-hand side, I'll highlight that when we looked at the factors that were associated with an increased odds or hazards of death, we found a few factors, age maybe not being that surprising, that as age increases, the hazard of death increases. But I'll highlight at the bottom that when individuals have better reported quality of life, that they have a reduced hazards of death. Additionally, social support, when we measure social support, individuals who report increasing levels of social support, meaning they have formal or informal connections, that their odds or their hazards of death actually decrease. And this really, I think, signals what I'll talk about in our next slide. And I've really taken this quote of connection is key for the SHAPE study. Anybody working in the SHAPE study, Tim Wessling has really coined this term, connection is key. And I think it is just so fundamental to the work that we're doing within SHAPE. And I'll kind of pick up from this social support measure that we've used in SHAPE before. And the MOS-SSS scale is a validated scale that measures these informal and formal sources of support that people receive. And within SHAPE, we looked at this scale and we found that social support scores were higher among individuals who are in relationships, individuals who reported having stable housing, individuals who didn't report having other mental health diagnoses, individuals who hadn't reported a history of violence, and those who were sexually active. And we see these are quite important, not just for health outcomes, but I'll highlight that we found that for every 10-unit increase in social support scores, the odds of having an HIV treatment break was reduced by 10%. So really suggesting that social connection is great, not only for individual health outcomes and quality of life, but we see that it actually reduces the likelihood for adverse outcomes such as treatment breaks. And I'll highlight that with SHAPE going through a few waves. So we opened in January 2016. We've had 3 waves of the survey, and we ended the follow-up of the survey in September 2021. We've gone through this great process with our very engaged SHAPE steering committee, and we've been meeting over the last few years. And it took us, I think, some time to figure out how we were going to reconceptualize what SHAPE was designed to do, with an acknowledgement that the first version of what we did with SHAPE really evaluated what the impact of the Stop HIV/AIDS program was. And when we heard from community partners and community organizations, 4 things really came out as being key to look at this going forward. We've really done a great job demonstrating the impact on HIV clinical outcomes, the impact of Stop HIV/AIDS on clinical outcomes. But moving forward, we're in a different landscape of what HIV care and treatment looks like. And so the things that were really told to us in terms of future directions and priorities included looking at HIV and longevity. And this isn't just biological aging, this is quality of life and quality of aging with HIV. Investigating and understanding access to mental health and substance use care for people living with HIV, for those that have mental health or substance use challenges. The piece of social connection and community connection, so access to community and social supports, both informal and formal. And then lastly, really evaluating these patient experiences in healthcare. HIV care is not as simple as just taking medication. There's blood work, there's pharmacy visits, there's nursing visits, there's connection to community organizations, and we really need to evaluate all of this. And we're really hoping, I've put this tentative date of January 2024, that we'll be able to reopen SHAPE to evaluate these priorities. And others have shared this, and I think our vision for SHAPE really aligns with this, is that there really is another 90 in the 90-90-90. where we have 90% of people diagnosed, 90% of people on treatment, 90% virally suppressed, but we also have 90% of people with good health-related quality of life. And I think that is a critical piece as we're looking forward and looking beyond our clinical outcomes for metrics in terms of how we're supporting people living with HIV. And in terms of this last 90, a piece of this that I want to highlight is there is a wonderful group that has been working with the WHO to really advance the sexual and reproductive health and rights of women living with HIV in Canada. And through this really wonderful process of meeting with community as well as academic scholars and clinicians to understand how we need to advance and prioritize the sexual health and rights of women living with HIV. And I'll just encourage you to follow the link here and review the suggestions and calls to action for those in working in HIV across Canada. And very quickly, before we wrap up, I'll just highlight that we mentioned that while we're doing a really great job of supporting people living with HIV-specific outcomes, there are other considerations that are really prevalent among people living with HIV that we need to consider. And I'll highlight these data from the Canadian co-infection study. And this was a snapshot shared in 2018. So this is around the time that direct-acting antiviral therapy was made universally available in BC. And we do know, and we have seen that there's been a lower uptake of hepatitis C treatment among people living with HIV, despite having really excellent cure rates, meaning that individuals who are offered treatment often have excellent, if not similar, outcomes to people who aren't living with HIV. And the work in BC, and I'll share this cascade of care done for hepatitis C from the BC CDC, really demonstrates that we've made some strides. And this is really comparing in the light blue bars the data from 2016, and then the dark blue bars in 2020, really demonstrating that we've seen increases in uptake of treatment for hepatitis C. This isn't specific to individuals living with HIV. This is specific to the entire province. But Dr. Bartlett, Sophia Bartlett from the CDC, noted in this paper and in this work that there are particular barriers for certain populations. And in particular, people who use drugs are least likely to be treated once they have a confirmed case of hepatitis C. And so these health system barriers or health system challenges are not unique to hepatitis C. We've seen this in HIV as well. So I think there are some translatable lessons for hepatitis C. And I've taken, if you recall the slide from the beginning of the presentation, this paper from the historical review of HIV prevention and care initiatives in BC and tried to adapt it for hepatitis C. And I've tried to highlight in red some of the areas for potential improvement or expansion so that we really can take the lessons learned from the rollout of treatment as prevention in BC and start to see where we could enhance this to reduce some of the barriers to life-saving treatment. A big piece of this that I really commend folks in the Hep C community are really trying to scale up things like peer education and outreach and reducing some of the health system barriers for accessing hepatitis C. I think it goes without saying that the illicit drug toxicity crisis in BC is devastating to our communities. And this is true for the population and communities of people living with HIV. In fact, 2 years ago, we published a paper demonstrating that the overdose mortality in BC is actually reducing the survival gains that we had achieved from antiretroviral therapy. And I think this is really a call to action to understand how, through a syndemic framework and looking at the intersection of substance use and mental health and hepatitis C, as well as HIV, really needs to be at the forefront of how we are looking at this as a health systems issue. And I'll share this as a plug for future work that we're doing at the Hope to Health complex in the downtown east side. And we've really conceptualized this as reframing population-specific healthcare. And we did a pilot project last year looking at how we could scale up hepatitis C treatment and access and linkage to care for people that use drugs. And I think our big takeaway from this project is this idea for healthcare of if you build it, they will come is absolutely not the motto for healthcare and healthcare equity and access. And I think we're demonstrating through some of the work at Hope to Health how a tailored patient-centered approach to healthcare, including options for low barrier access to healthcare through sites like the supervised consumption sites, are a really powerful way to engage individuals who are experiencing a lot of pervasive barriers to healthcare. So I'll highlight that in the sample of 188 people that we surveyed at the supervised consumption site, when we asked them, do you have a primary care provider, about a third of them said no, and about a quarter of them said they had not been to the doctor in the past year. And in fact, the idea of avoiding healthcare was something that was very pervasive. So I'll close with saying that monitoring and evaluation and research that is embedded in health service delivery, I think we've demonstrated in HIV is really critical to enhancing health equity. That this treatment as prevention paradigm, which I think is a very simple but beautiful example of how equity and access to treatment and universal access should be encouraged, can be applied to many public health issues, and I've demonstrated hepatitis C as one example. And that this endemics model of understanding the intersection of various epidemics and public health emergencies really supports us to think more towards a equity-based population-specific versus a disease-specific health service planning. And I'll just plug that we will be excited to share more updates from the SHARE and SHAPE team as things progress. So thank you very much, and I'm happy to take any questions as well.
Thank you, Kate. While we wait for some questions, Kate, as you were talking about the importance of, and we have this conversation before we started the webinar about the role of the peers and so on. So the SHAPE and the RETAIN studies have involved many peers in their development, implementation, analysis, and presentations. Can you speak about the value and the insight that peers have brought to these studies?
Yeah, I'm happy to. So I think our research and also our anecdotal and personal experience really validate and demonstrate that peers are absolutely essential. I think connection to community, connection to folks that have shared lived experience is something that we just simply, other clinicians just can't provide that, frankly. And we've seen in the SHARE and the qualitative research that we've done that peers are often this bridge that offers support to healthcare from individuals who are really fearful to go to their, as well-meaning as they may be really fearful to go to their pharmacist or to their doctor. And peers can often be that first bridge of contact that offer a non-judgmental, supportive hand to connect with HIV care. And there's a real potential for, I think, us to learn from HIV care in terms of the role of peers and peer navigators in translating that to the way we enhance patient-centered care in other types of healthcare as well. And I'll highlight that our community researchers have been instrumental and are true partners in the work that we've done, and I really don't think we could do this research without them.
Thank you. You talk a bit about the social supports and the key that social supports have in HIV, but how the social support were impacted by COVID-19 and possible influence of HIV care?
That's a good question, and we looked at the role of COVID on things like treatment breaks in the SHAPE project, and we had assessed to see if not just before and after, but at different points in the COVID pandemic, if we saw that there were higher than normal rates or elevated rates of treatment breaks. And encouragingly, we didn't see that there were elevated rates of treatment breaks. So it does look from the data that people were able to be retained and and sustained on antiretroviral therapy during the COVID pandemic. However, we do note that in that same work that there was an increase in transitioning to things like virtual care, that we know for the first year of the pandemic that viral load testing decreased, and thankfully, despite decreasing volume of viral loads, we still saw that there was promising clinical outcomes. So I think this work is really encouraging for the fact that we didn't see increasing treatment breaks during COVID, but I'll highlight that that doesn't necessarily mean that quality of healthcare or the quality and interactions of healthcare. We've heard in the SHARE study how much COVID impacted people living with HIV. And I think this highlights again the work that we're doing in the SHAPE and SHARE project, that clinical outcomes are important to evaluate, but the types and quality and experiences of care are equally important. And I think we're really honored to hear from people that wanted to share with us how hard COVID was for them, and often honestly re-traumatizing for a lot of people who have lived through multiple pandemics and epidemics at this point. So encouraging clinically, and also I think a little bit of food for thought in terms of how our health system can continue to provide equitable support for people living with HIV during these kind of tumultuous times.
People living with HIV are increasingly greater risk of other comorbidities. What are some of the key comorbidities that we need to be aware of that are associated or linked to HIV or part of the HIV?
Well, I think there's two parts to that. One is that we have seen that there are certain conditions that are age-related comorbidities that are similar to that in the general population, but they're occurring at much earlier ages among people living with HIV. And Deetha, and working with Dr. Lima's program, did this wonderful analysis that came out a year or two ago, really looking at certain comorbidities among people living with HIV. The onset of those comorbidities were sometimes 15 to 20 years younger than their counterparts in the general population of people living with HIV or without HIV. And I think that has important implications for things like screening and the types of clinical care that people living with HIV need. So one part of it is the idea of these earlier onset of comorbidities. And then the second piece is there are conditions that are more prevalent or more common among people living with HIV. We see that we've done an analysis within our cohort here in BC and found that about 80% of people living with HIV reported some form of mood or anxiety disorder in their lifetime. And I think this really highlights the fact that mental health tends to be the secondary component. And in our research, and when we hear from people living with HIV, it's not a secondary component, it is the number one component. And so mental health, substance use, and supporting people to live healthier lives is a huge part of that. I'll also very quickly highlight, because I think this is a topic close to my heart, is also recognizing the increased risk of certain types of cancer among people living with HIV, and understanding that viral-related malignancies, so things like HPV-related cancers, are quite elevated among people living with HIV. And so screening may need to adapt to reflect those increased risks.
You showed this beautiful slide that shows the decrease of over 90% of AIDS-related mortality. And as HIV has become more manageable in terms of controlling the viral, suppressing the viral, improving the immune status of people, and so on, what are the risks of stopping investments that are required to sustain some of these gains? So you already show the decline on the number of new HIV cases and AIDS mortality. So is there not a risk for funders to come and say, hey, you're doing so well, we'll need to focus on something else?
Yeah, I absolutely. I think we some people, I don't think many of us working in the HIV community, but I think some people may say, oh, the HIV incidence has declined, we've reached endemic levels, we can kind of let our foot off the gas, so to speak. And I think for anybody that's working in this area, I think we would all, I don't know anybody who would disagree with the fact that the reason we've been so successful is because we have implemented, if I go back to that triangle, we've implemented, the foundational pieces of enhanced treatment and testing and prevention, but we've also gone above and beyond with quality improvement interventions, community outreach to address these issues of equity. And what I would personally fear is that if we let our foot off the gas, the first people who would suffer would be individuals who are continue to be facing structural oppression and structural violence. So we would see women, we would see people who use drugs, we would see people who are houseless, tend to be the first folks that would be impacted by that. And I don't think anybody wants to see that, letting our foot off the gas, so to speak, I think would just first lead to a great deal of health inequities, and it would potentially really slide us back from all of the success we've seen in the province of BC. And I think it goes back to that fourth 90 is, we really need to see that it's not just viral suppression, but it is true quality of life. And, just because the incidence is decreasing, we still have a large population of people living with HIV. And I think we can't neglect the fact that continuing to support them and their health outcomes, but also their quality of life, it really does need to be a priority.
Thanks. You already show us also data about the impact of treatment as prevention on the HIV epidemic in BC. You also talk a little bit about the possible application to viral hepatitis and possibly substance use. Mm-hmm. Is there any other examples where treatment as prevention could be applied to that lead to some better control of conditions, key conditions?
I think hepatitis C is, I think, a reasonable example of where increased access and universal access to treatment can decrease incidence of new infections of hepatitis C. We've seen data from the Netherlands that have really supported that, and that's really informed BC's approach. And thankfully in 2018, the Ministry of Health decided that they were going to approve and support access to hepatitis C treatments, direct-acting antivirals. However, we just haven't seen the uptake of treatment that we were expecting to see. And I think if we go back to that slide where I showed what really was working, that Michelle Olding slide, which really demonstrated the health systems approach, I think it just demonstrates that it's not just better treatment, and Hep C certainly has better treatment. The advent of new medication is incomparable, and yet we haven't seen this radical uptake of treatment. And in fact, we still see pervasive barriers for a lot of priority populations. And so I think there's room to apply that to hepatitis C. I also think that there's a lot of room to apply that for substance use. We know that the illicit drug toxicity crisis is continuing to devastate our communities, and there are options to effective and safe medications, and that includes opioid agonist therapy, but it also includes prescribed alternatives, or what I think is often referred to as safer supply or prescribed safer supply. However, it's often been noted that there's barriers to accessing those, and that I think calls to a bigger issue of health systems response to tackling those issues. I think if I can use the example as well of mental health conditions as well, some of the work that we're doing is really demonstrating the high proportion or high prevalence of conditions like psychosis among people living with HIV, and the relatively low uptake of antipsychotic medications. And so I think there's a lot of opportunities for thinking about this treatment as prevention paradigm. I think it often gets is synonymous with this idea of like an infectious condition, but really any condition where we're looking at optimal treatment and optimal sustaining somebody or sustaining clients to have more favorable treatment outcomes. That's really what we're talking about with treatment as prevention. So that thinking, that framework can really be applied to outside of the realm of infectious disease and more as a paradigm to promote health equity and treatment access equity as well.
Yeah, and then certainly Julio Montaner has been in direct conversation with Diabetes Canada, who has already adopted the cascade of care, obviously applied to diabetes, and also the Respiratory Diseases Consortium that recently formed in BC to look at COPD and asthma and other conditions. So there's great opportunities to expand this. But I wanted to ask you, what are the key elements of what made you have a table, you outline some of the 3 areas or 4 areas that you talk about, but the integration of research, evaluation, guidelines and education and so on. So what are the key elements of treatment as prevention that could be extrapolated to other conditions?
I think and this the first thing that comes to mind when we talk about some of the implementation issues that happened in BC is that the BC-CfE really championed provider training, and the BC Centre for Excellence has a wonderful clinical education department, and right now it's led by Dr. Val Montessori, and being able to support prescribers, support providers to feel confident, to feel comfortable in how to provide the best care for their clients living with HIV, I think is an outstanding example of addressing some of these treatment gaps. And BC has a unique example where we have made this decision to not hold HIV care in just specialists or specialist roles, and instead we tried to support family docs and primary care providers and other providers to have the training, to have the skills, and also just to have the support with treatment guidelines and provider guidelines to take on and support clients living with HIV, which we found is better for continuity of care. It's better for healthcare relationships. And I think that's a really good example of what we can do for other conditions. So hepatitis C, for example, there's been a real and intentional shift for providers and prescribers and community to support their clients who are diagnosed with hepatitis C. And the same can be said for substance use. A lot of family doctors can get trained and supported to prescribe things like OAT or safer supply. And so opportunities to really enhance provider training, I think is one key thing that we've taken away from the HIV response in BC, as well as I think collaborating with community providers. I think there's wonderful examples of where people are able to get really wraparound, comprehensive, low barrier care in community. And those aspects of addressing the psychosocial care are just so integral to supporting the health and well-being of clients. And I think our community partners would attest to that as well.
Right. You talk a little bit about the social supports and so on. Do you think that stigma, HIV stigma, is still a problem?
Yeah, we sadly in the SHAPE study, we had investigated HIV stigma, and we do see that it's quite high. And as a group, we were thinking about stigma, and we had thought perhaps, oh, well, maybe the time that people are living with HIV, as they live longer with HIV, maybe that HIV stigma wanes, or maybe it changes over time as well. And I think what we learned from this research is it doesn't. And that to us was a big learning point, that HIV stigma is pervasive, and whether you were diagnosed a year ago or 10 years ago or 20 years ago, it still is an important factor. It impacts how people seek care, how they disclose, when and where they feel like and to whom they feel like they can disclose to. And that's not just in interpersonal and social relationships, but with healthcare providers as well. And so I think stigma isn't something of the past. Just because we have newer therapies doesn't mean stigma's gone away. And I think keeping that in mind is really critical. And I think there's been really wonderful work done in the HIV stigma world as well. So I'll highlight that, there's lots of people championing this work. And I know organizations like PAN have done a really wonderful job at really trying to highlight the role of stigma and HIV-related stigma among people living with HIV. And I'll highlight that we also talk about this like intersectional oppression. So there's lots of different forms of stigma people experience. That can be in the form of sexism, in heterosexism, in racism, in transphobia, and those are all parts of. It's not just HIV-related stigma. There's multiple intersecting forms of stigma and discrimination facing people living with HIV that are, I think, important to keep in mind when we are talking about this new era of healthcare and moving towards health equity in the TASP era.
Thank you. There is a question from the audience here that I'd like to pass on to you, and the question reads: are we going to see injectables, antiretrovirals, as part of our future? Yeah, as a non-prescriber, I'm probably not the best person to ask, but I think I'll speak to kind of the process in BC, that there is a drug therapeutic committee at the BC-CfE. I think folks like yourself and Dr. Montessori and many other clinicians are reviewing new therapies regularly, and that process of vetting or seeing what drugs get approved in the province are done so through a collaborative effort with pharmacists and prescribers. And I think as evidence continues to grow in this area, we'll have more options as we have better options for clients living with HIV. Thank you for answering for me. No problem. And in fact, the injectables are already here. Unfortunately, they are still not the type of injectables that will benefit the overall HIV population. The ones that are being marketed are having a relatively small scope, or at least tested in a very specific populations that are not. So that makes that the rest of the population cannot benefit it until the evidence comes available. But it's a future for sure. And it will start to emerge soon. Yeah. So hopefully. And I think that highlights the fact that there is this push for medications like injectables. I think the idea of having something that is that you can take less frequently, that is injectable, that isn't client delivered, is something that's, I think, really welcomed by the community. It's welcomed, and doing so in a way that making sure the medication is the right medication and safe, I think, is something that's overseen by the therapeutic drug committee as well. So I trust the process. Good, thanks. I'll set you back a little bit on the topic that we started the conversation, and has to do mostly with these syndemics. So how we apply this to these various other conditions that are intersecting with HIV? Yeah, I think that's a really good question. And I'll say, I think the shift in HIV care from specialist-driven care, and not to take anything away from specialists, but I don't think any client, I don't think any user of the healthcare system wants to go from doctor to doctor to doctor, or go to specialists, or have a lot of waiting times, or have to go to 7 different places to get their health care. I think that's true for anybody, and in particular when you have folks that are houseless, that are facing multiple structural vulnerabilities, that becomes ever more present in the conversation.
And so this idea of syndemics-driven care really is a very academic lingo for saying population-driven healthcare. And so population-driven healthcare should be driven by the population that you are serving. And that means having healthcare that reflects the realities of people in your community. So if substance use or mental health is the #1 priority for your community, then ensuring that the support that you're giving as a healthcare facility, whether that through nurses or peer specialists or social workers, that should be part of the focus and training and support for the care being offered there. Same with HIV, same for hepatitis C. And I think there's examples of that where the population-specific healthcare is the focus. Hope to Health is a good example of that. You have facilities like Oak Tree Clinic, which I think is a good example of population-driven healthcare, understanding the population and then providing the adequate supports versus having a healthcare service that delivers one type of healthcare that will address one part of a client's needs. And I think with the current primary healthcare crisis in the province of BC, I think in terms of supporting health equity and access, this is absolutely essential.
I will ask the last question, and it's a bit more personal. Would you change your career for other topic?
No, I don't think so. I think
what makes you to do that?
I think anybody, I was just talking about this with somebody the other day, and I think anybody who ends up in this area does so intentionally. I think that the reason that most of us are driven to work in this area and are fortunate enough to work in this area are driven to do so because there is a genuine passion for health equity and social justice, and also a curiosity and a dedication to figure out how to make things better. And I think recognizing our role as researchers, that is truly our role. And it's not the only role. We have the fortune of working with clinicians and healthcare decision makers and community experts and advocates who really drive this work and really are the soul and heart behind everything that we're doing. So we certainly don't go about it alone.
So I just got another message from our audience, and essentially thanking you and pointing that it was a great presentation. I would echo that for sure. And working with you has obviously led me to know more about your work, and of course I'm quite impressed with the quality that has been emerging. So thanks for doing that presentation for us today. At this point, we're going to have to bring this final chapter of our discussion to an end. Thank you for your questions, and then thank you, Kate, for your discussion of the application of treatment as prevention to HIV and beyond. If there are any additional comments, questions, or feedback from the audience, please email the education team and they will do their best to respond to you. Thank you.